those of you that don't know who I am, I'm Vernon Brown. I'm one of the co-founders of Stewards of Change, and it's a privilege to be here today and introduce the first panel for the conference. And I want to thank Dr. Ray again for that inspirational, kind of intellectual thinking and contexting the discussion. And I think it's something that allows us to be able to move into the body of the conference in a way that we all hoped it would, which is having the opportunity to reflect and to think in a different way, and the challenge around the change that we're all experiencing across the country, particularly in the health and human services sector. And so the panel that's going to come here next is focusing on giving you a base from which you will be able to share across the rest of the conference the actual interoperable initiatives that are occurring within the federal government at the health services level. And we've got a distinguished panel. I'm going to introduce them just briefly. Their biographies are available for you to be able to look at, and the order in which I introduce will be the order in which the presentations will occur. And so we'll have Dr. David Hunt, who's the medical officer for the Office of National Coordinator for Health Information Technology, more affectionately known as ONC. Yeah. And he'll be followed by Susan Lamson, who is the Director of the Division of Information Technology and Community Assistance, and she'll be able to give you a really robust introduction to where we're at the community level. Rick Friedman, unfortunately, is dealing with meaningful use. And he gives his regards. As many of you know, the rules for meaningful use were promulgated the day before New Year's, right? You kind of think about, well, did they do that? Because it's like, you know, how when you want to have something bad in the press, you do it on a Friday, you know? Well, they did it on a Thursday before a long weekend on the first of the year. And so he feels as if he needs to be present to field the many questions that I'm assuming were in his email this morning when he walked into the office. And so we have Denise Bazemore, who's going to be part of the presentation. She's the technical director for CMS for the Center for Medicaid and State Operations. And then also Robert Guenthur, who's also the technical director, and he is with the Center for Medicaid and Medicaid Services. And I'll let them talk a little bit about their areas of expertise and the areas that they oversee. And then we have Jerry Friedman, who's here today to serve as the chorus for the states. Jerry's the executive director for APHSA. Many of you know him. He's been with APHSA since 1993 and has had a distinguished career in the public sector in both Texas, Washington, and Pennsylvania. Okay, so without further ado, I want to allow our speakers to give you a sense of where interoperability is across the country in the federal health sector.
Let's see. Thank you very much. I bring you greetings from Secretary Sebelius and from Dr. David Blumenthal, the National Coordinator for Health IT. I always start all my presentations with a little bit of a disclaimer very, very quickly. I like everyone to know I'm a practicing surgeon. I only say that so you'll understand how no matter what the subject is, everything will eventually come to just talking about me. So I'm absolutely thrilled to be here because of the exciting issues that we're discussing are really coincident with one of the most transformative moments in American medicine. You see, 2010 will be among the most interesting years we've ever seen. And my office, the Office of the National Coordinator, is charged to help describe what can make this year and at least the next 5 or 6 hereafter meaningful with regard to health IT. Now, given that statement and our office name, I suppose a reasonable assumption is that I'm here to talk about health IT, but you'd be wrong. That's not that what this meeting's about, and interestingly enough, that's not really the primary focus of our office. Now, it sounds like I just contradicted myself, Sure, a good deal of our programs and program resources that I'll discuss have an obvious association with information technology. But a more appropriate way to describe our mandate from the President and Congress is that the Office of the National Coordinator has been given unprecedented resources and authority to effect an improvement in the value and efficiency of healthcare services through the meaningful use of information technology throughout the country. And the need for this is pretty clear. In 1998, Cyril Shantler clarified it as well as any. He pointed out that years ago, medicine used to be safe, simple, and pretty ineffective. Today, I practice in a world in which my efforts can be very effective, but almost everything about that practice is more complex and dangerous. So understand that at ONC, we have a firm conviction that properly applied information technology, properly applied tools, can help me as a surgeon be more mindful of my patients, learn new insights into the care I deliver, and improve the quality of that care. But I spend a lot of time managing expectations to make sure we're careful not to fall into the trap of thinking that everything will be just fine if we just wait for the folks who gave us Google and eBay to do their thing. But I think you all in this hall understand that's better than most and appreciate the fact that health IT is just one piece of a much, much larger solution. The compelling solution for 2010 and beyond pivots around the simple question: can we use information technology as a vehicle to change our culture and, in turn, our methods in 21st century American healthcare? Well, I mentioned that earlier that the President and Congress gave the Secretary in our office a mandate. I think it's very helpful to look at just briefly at the text of that mandate. Here I've taken a section of that text and highlighted some key words and phrases. It starts with security, quality, and cost. And we also see throughout that the overarching subtext is to improve the quality of care while making sure that the information remains secure and supports our institutions of public health and human services. To improve, to ensure, reduce, protect, facilitate, promote. This is a pretty formidable list of challenges. But again, I ask you to take note that the transcendent goal is not to acquire cool hardware. The point is not to have the latest software. The infrastructure is a means to an end, or it is nothing at all. But don't let me get too far ahead of myself. I have it on very good authority that I always have to speak to my take-home messages before I get very far along. You see, I'm not ashamed to recount the public speaking advice that my daughter once gave me. She told me, "Dad, don't take this the wrong way, but you must bottom line your audiences very early on. Because when you speak for more than 5 to 10 minutes, you become very boring and tedious." Who could take that the wrong way? The first thing I want you to take home is that this moment in time, possibly more than any other, is a time for clinical leadership. My brothers and sisters who have taken an oath to care for the infirm must step up. And next, while we lead, I think the essence of this conference points to the fact that we must be the first to acknowledge that our work is a team sport, and any success we have is wholly dependent on the strength of our partnerships. And that brings us to the final point. Please rest assured that no direction beyond this one will be easy. And while I won't promise you only blood, sweat, toil, and tears, we must understand that the path forward requires a system, tremendous resources, and no small amount of courage. And with those acknowledgments, looking at all the promise that interoperability holds, I will say that our office at ONC, our first and steepest challenge, is spurring the adoption of health IT in the clinical practice. Here you see some very newly published and, in some ways, preliminary numbers on the state of EHR adoption by physicians. Looking at practicing physicians, we see that in 2008, only a little more than 4% were using an electronic health record that could do the work that we need. Today, it looks like we've increased that number by 2 points, which still leaves us a long, long way to go. And why is that? Why are we still in single digits for adoption? Well, the answers are pretty clear. Here, we see the top 6 barriers to adopting an electronic health record. In short, for many of us, it has not been worth it. Collectively, we in the clinical community have been very clearly saying that to embrace electronic health records, there must be a value proposition. Our needs must be met. Those needs really must be met. So I use this slide nearly everywhere I go because I find it such a wonderful construct to frame our challenge as well as our solutions. This diagram is from the work of Abraham Maslow, who in 1943 described a theory of human motivation. In it, Maslow essentially divided our needs into growth needs and deficiency needs. Deficiency needs are physiologic. They must be met first. And once met, the individual seeks to satisfy the needs of growth. We can apply Maslow's hierarchy to our current circumstance in health IT, and in doing it, we will assign the foundational need as privacy and security. Beyond that, moving up the needs of growth, we see the components of usability, basic functions, a strong business case, and finally, at the top, a most fulfilling achievement, health information exchange. Now, let's look at how those requirements will translate into action from our office. I mentioned earlier that privacy is the foundation for moving forward, and the reason is obvious. The tenets of privacy are old in my profession, and the Recovery Act clearly speaks to this point. And beyond the delivery of patient care, all of the human and social services that will be discussed in the next 2 days will require a strong fabric of trust. Fortunately, to help us build the infrastructure that will support that fabric of trust, Congress has provided that we have more than a policy of good intentions. This is a serious endeavor, and our intent at HHS is to create durable, measurable, reliable improvement in health care. So, one of the first issues we are addressing is how do we help providers choose and effectively implement this technology? Well, a few months ago, the department released a framework regarding how we can help with technical assistance through health IT regional extension centers. And over the next few months, I hope that we might be able to announce which organizations will be the first out of the chute in providing that assistance. The goal of these centers will be to provide hands-on technical assistance in implementing the technology. Now, they'll do this for more than 100,000 physicians, and our office will spend nearly $600 million on this. And that assistance is specifically directed at providers that are least likely to be able to do this on their own. Here you can see that those awarded grants must prioritize assistance to those historically underserved areas with the ultimate goal of reducing healthcare disparities. Reducing disparities is a primary goal, and clearly our needs in this regard are as acute as ever, which really explains the recent headline that there is even more evidence of a growing digital divide in healthcare. You see, if we believe that information at the point of care can make a difference in the quality, value, and safety of that care, and what is more is that this information can go on to support institutions of public health and social priorities, then the imperative of these findings become much more critical and are more easily understood. So, this begs the question of why Rick isn't here. What is meaningful use in health IT? Well, as you heard, we had an announcement over last week, and I have to give yet another disclaimer again to tell you that because we've just published the rule that we've officially entered a comment period, which may be why Rick was smart enough to stay home. It means that I can't provide any interpretations beyond what is published on what that says. The good news and the announcement of tremendous import is that we are collecting comments on it. Clearly, we believe that the proposal meets the requirements established by Congress in the statute, and that statute gives some pretty clear contours for meaningful use. For example, the electronic health record must be certified, and we must be on a trajectory that includes exchange of information of real value to the patient, such as care coordination. So let me get back to the most important thing I can offer, namely that we publish this as a proposed rule. And we are desperately asking that everyone to whom this rule is relevant submit a comment. No, let me correct that actually. We are begging everyone to whom this rule is relevant to please send us a comment. Now, the gift of this opportunity to speak to you is the price that a brief presentation clearly doesn't provide an opportunity for more than a cursory acknowledgement of our programs being launched for health information exchange, workforce development, and Beacon Communities. That last program, Beacon Communities, really holds the greatest promise for interoperability, because in those communities we are looking to see the full flower of what this technology can achieve. And finally, I'd be remiss if I didn't highlight one other area to show that there are other provisions to this work not necessarily related to, strictly speaking, health IT. And in this case, I'm speaking of comparative effectiveness research. This investment will obviously benefit all Americans, but it is clear that some of the greatest value will be in communities and groups that are not traditionally included in research protocols. It's funny, my 12-year-old son overheard me describing comparative effectiveness research one day on a telephone interview to a reporter. I was saying that now we will begin to find out what treatments work best. Well, he heard that, and he looked at me funny, so I asked why he was so puzzled. And hesitating, because he wasn't sure that he heard me correctly, Daniel asked, with this new research, we're going to find out what treatments work best. I said, yes, Daniel, that's exactly right. Well, we happened to be in my library at home, and he was surrounded by shelf upon shelf of medical texts, and he looked around at all those volumes and asked a very salient question. Well, what have you been up till now? And this really, his question really speaks to my central thesis, namely that our current circumstance is not solely due to a lack of technology and cannot be solved with technology alone. It is no small matter that two of the statutory criteria for meaningful use involve information moving, information exchange. The whole point is to provide a means to facilitate communication and the transfer of information, and possibly even the transfer of knowledge. In the right hands at the right time, information can be transformative. The full, complete, and regular exchange of medical information will represent a singular change in our culture. And I can think of no better way to increase the value of our services than to make their provision fully informed. The alternative, well, that's equally remarkable. To continue each of us in our own silo, putting one new innovation on top of another, with no real consideration of how one piece informs, supports, or confounds another, means that we will keep our current haphazard and dysfunctional method of taking care of patients. It means that we will recreate the experience of Babel. So, I hope you understand, while necessary, computers are not the whole answer. Because the question is not how much technology do we need. The question is, how do we improve the quality of care for all Americans and affect that elusive yet self-evident truth that among our unalienable rights are life, liberty, and the pursuit of happiness. Now, while I am frequently prone to exaggeration, this is what I think we're here to discuss, and it is not hyperbole. Because I've seen that pursuit go slower for our kids that aren't immunized. Preventable cancers have separated far too many of our people from their right to life. And the full flower of liberty is not as apparent to those that rise every morning with a disability, with Alzheimer's, or with HIV. Now, a computer won't make that right, but information technology can assure that a pediatrician sees a list every morning of the patients coming that day that aren't up to their immunizations, as well as their brothers and sisters who will probably be in tow with mom when she arrives for the appointment. Every man and woman having an electronic record means that our best minds can really ask and answer the question, what treatments work best for a 48-year-old Latina with breast cancer, or a 56-year-old African American with node-negative prostate cancer? And what are the full portfolio of services they'll need to effectively implement that treatment? Now, a computer won't rid the world of AIDS, but it will afford well-meaning people the liberty of having their care coordinated in such a way that every one of their doctors knows all the results of all of their tests. You see, 9 years ago, the Institute of Medicine got it right. Quality care is effective, efficient, safe, patient-centered, equitable, and timely. But just saying that won't make it real, and it only begins to describe what we need to do to reform health care. With information technology, we can see the true choices and the balance that must be preserved. That balance is really highlighted in my reality as a 21st century American surgeon. And the reality that stands in immediate juxtaposition with the fact that no country, no national enterprise has fully and successfully implemented what we are attempting to deliver. I used to end my implementation presentations with a quote from Voltaire. He used to say that doubt is uncomfortable, but certainty is ridiculous. And while that's very true, as we stand on the cusp of this brand new year, I appreciate Mr. Twain's observation even more. Namely, that we are about to understand things that could have been learned in no other way. We are willfully and purposely grabbing this cat by the tail. So please, send us your comments on our proposed rule for meaningful use and help us figure out things before we get too scratched. So with that, I'll stop, and I'll say it's been an honor to be with you, and I look forward to hearing more. Thank you.
I have a question. When we were speaking earlier about the application of this work and this thing towards other sectors of the other sectors and other federal agencies, the conversation revolved around how do some of these efforts affect human services as well as education. And could you speak a little bit toward that?
Sure, and that really, and as I said, the first big threshold that we're trying to cross is making sure that we have a critical mass of these systems with information actually being entered into it to be useful, that the sharing of information will be robust and moving forward. But it is very, very clear that so many programs, so many social service programs touch and require and hopefully use health information in a meaningful way. Every school nurse really needs to have a medical record. The Head Start programs, everyone who enters has to get a medical examination, and to have that information to be able to be shared among social service departments is incredibly important, which is why I said one of the most important programs that we're standing up, one of the most exciting and important programs that we're standing up is that of the Beacon Communities. It's run a little bit below the radar because heaven knows the tsunami of what meaningful use is has been grabbing all of the headlines. But in Beacon Communities, what we're trying to do is select about 15 communities that are a little bit further ahead in terms of health IT. And in those communities, we're providing resources to help fill in the gaps. They've already gone and made most of the big steps, primarily among in the area of building partnerships among stakeholders that want to share information. And in these Beacon Communities, we hope to see some of those final connections being made. So we'll see even more robust connections to the departments of public health, but even more of that, departments of social services. We're asking for proposals from about 15 communities. I think we plan to spend a little bit more than $200 million to help support some of these 15 communities as they begin to extend and advance what we're doing in terms of just the medical information. So I would say, if you want to look anywhere to where will be best, I would say the Beacon community programs. And for those of you who are actually in and working with communities that, again, are a little bit further advanced, not necessarily because you have hardware and software, although that's wonderful. If you already have health information exchange, that's perfect. But the most important thing is that that the communities have gone that extra step and begun to make the connections between stakeholders that have been able to say, yes, we want to share information. One of the biggest thresholds for that is actually something a lot of us don't think about. Hospitals don't share information. Because they are competitors. And you never think about that. They're all working in the same marketplace. They're all vying for the same patients, hopefully with good, robust health insurance. So getting the best example is where Dr. Blumenthal came from, Boston. Getting information from Mass General over to some of the sister hospitals that are equally renowned is there's a huge and virtually impenetrable firewall, actually. And so one of the things that we want to see in Beacon communities is that those walls aren't down. Not that they necessarily have the best health information exchange in the world, because that's a technical problem, and that actually is the least of the issues that we have to discuss. The biggest thing is that they've begun to make the community and stakeholder connections that will help hopefully allow the real exchange of important information.
One last question.
HIPAA, one of the rules of HIPAA is portability.
Mm-hmm.
So wouldn't it be natural for hospitals to take the next step in information sharing?
Natural, you know, it's the old saying, common sense isn't common. Natural, you would expect that. But what we see, first let me say one thing. With HIPAA, with the HITECH Act, the basic statute that actually formed a lot of the programs that we are in ONC are producing, radically enhanced and improved on HIPAA, particularly around the issues of health information exchange, because there were some technical areas where it was unclear. We've increased the number of those who are under the business associates rule, which means basically, not to get too inside baseball, which basically means if you're touching health information that you still have a duty to make sure that you maintain the privacy and security of that information and the confidentiality of that information. So HIPAA was expanded with HITECH. But the fact of the matter is that all of the statutory regulations will mean nothing if we aren't able to build a landscape where institutions see that it is in their interest to actually share information. Great example is where I come from in Washington, D.C., in my practice. Great Daughters of Charity, well, now Ascension Health System Hospital, actually owns a nursing home, and they often get patients from nursing homes in the surrounding community. They are, for lack of a better term, not to be pejorative, many of the patients are frequent flyers. They come to the hospital all of the time, and precious few times do they come with a full slate of information, things that can be prevented. And that's because for the institution still, even though they're doing the same work, well, especially because they're doing the same work, they see themselves as competitors, and they've never built the channels for robust communication. So one of the things that we've been able to do, is we're starting to do more and more, is show them that it is in their business interest to actually share information a little bit better. I guess the best analogy would be, do you remember the old days, I'm dating myself, when WordPerfect and Word were two competitors and you couldn't share files among them, between them, and finally someone realized that we've got to have standards and we've got to be able to share the information. And, oh well, maybe that's not a good example because nobody uses WordPerfect anymore. But I guess that was that might have been. But the big point is, for the greater good, we have to be able to break down some of those walls, some of those silos that we had talked about before. So hopefully we'll be able to do this. But again, it is not a technology problem. The technology is here. The problem is really a cultural one.
Good afternoon, everybody. I'm Susan Lumsden, and I'm with the Health Resources and Services Administration. I'm very, very happy to be here today. For those of you who may not know HRSA, we are a small agency within the Department of Health and Human Services. Our mission is we're known as the Access Agency. Our mission is to provide quality health care to about 24 million, the slide is dated, to about 24 million Americans who in medically underserved areas. We have a budget of about $7 billion, and we do a range of activities with that budget. We work a lot with some of the same constituents that you do, a lot of state and local health officials and city and county health officials. For instance, we have about 1,100 community health centers that some of you may be familiar with that serve about 17 million people, providing primary and preventive services to those patients, and about 7,500 sites across the country. Those are migrant, homeless, community health. Some are school-based, and serving also people in public housing units. We also have a Ryan White program that serves some of the best care to persons with HIV and AIDS. We also are experts in our Maternal and Child Health Bureau, lead the federal agencies in their care to mothers and infants and children. Our program, we have a whole office of rural health policy that works and provides technical and financial support to rural hospitals and rural clinics to help keep them open and providing quality care. We also have a whole Bureau of Health Professions that works to recruit and train and place health professionals in these areas and these service areas. The patient that usually comes into our community health center, just to kind of give you a flavor, usually our clients are 200% below the poverty level. They usually come into our clinics with a chronic disease, be it asthma, diabetes, heart disease. They usually have a comorbidity. They're probably struggling with depression, maybe substance abuse. Socially, health probably isn't their number one priority. When Dr. Hunt beautifully talked about Maslow's hierarchy of needs, they're usually worried about their family's food, shelter, clothing, probably providing health care to their kids. Grandma is probably not really worried about getting her mammogram at this time. So in March of 2009, President Obama appointed Dr. Wakefield as his first political appointee to head HRSA as the administrator. And she has 3 priorities for HRSA. The first is collaboration. A major source of HRSA's strengths is in its many linkages and partnerships with federal agencies, state, local organizations. Achievement of our mission is very dependent on our partnerships, our effective partnerships with these organizations. And it's really to leverage resources, to create synergies and extend capacity to help address the many issues that we're all facing in the communities that we serve. The second priority is looking at performance, continuing to look at performance measurement. And the third priority is public health, with a key focus on prevention. I'm not going to go through these slides, but I think Dr. Hunt beautifully said the value of HIT in going forward. But I would like to comment on this one bullet point in terms of the coordination and integration of care for the patients that we serve is very difficult because the patients usually get their services from a broad variety of places. Immunizations is one. We thought immunizations was an HIT-sensitive measure that we could easily track. Childhood immunizations, that once you get HIT in place, boom, your immunizations ought to go up. Well, it turns out that, yes, children get their immunizations from all kinds of places, so getting that data was much easier said than done. I'm going to move along, and in 2005, HRSA created the Office of Health Information Technology, mostly to prevent the digital divide that Dr. Hunt referenced. And we were very fortunate at that time. Dr. Duke, our administrator at the time, appointed a Yale graduate whose extraordinary leadership and vision started our office. And she's actually right here, if you could just stand. Cheryl Austin Kasnov. I would really encourage you to talk to her throughout the 2 days. Due to her extraordinary leadership, we were able to accomplish quite a lot in the last 4 years. The goals for the safety net provider, again, I think Dr. Hunt referenced these. It's really to improve the quality of care, reduce health disparities, increase efficiencies, and decrease medical errors, and really to prevent a digital divide, and to help our providers participate in the future healthcare reform. The patient-centered medical home for HRSA is our foundation for HIT. We do see HIT as a tool, not an end in of itself. And our community health centers are experts in this area. They provide population-based management. Like Dr. Hunt referenced, if HIT can come in and help the patient-centered medical home to stratify patients so you get those patients who are in need of services, be it immunizations, colon cancer screening in first, then HIT has done its job. If it can increase provider-to-patient communication, if it can increase provider-to-provider communication, do quality measurement and improvement, and help enhance consumer self-management. What our office does is do two things. We have two focuses. One is policy and technical assistance, and the other is an operational focus. We give grants that are, we call them, they're like laboratories, both in the Office of the Advancement of Telehealth and our Health Center Controlled Network program. And both these operational grant programs are, we call them experiments and laboratories. They help us see what's going on in the ground. And having these two focuses, and this is what the Office of the National Coordinator is also doing, having a policy focus and a grant focus is very good together. One informs the other, and it's a very nice feedback loop. So you're always your technical assistance that you're providing to grantees is always up to date based on what's happening real on the ground. The next program that I'm going to be talking about is the program that I manage, and that's the Health Center Controlled Network program. The networks began back in actually 1994 to deal with managed care. It's a very basic premise. It really is talking about health centers coming together to integrate a function that they could better do as a group of themselves rather than individually. Finance is a key example. Many health centers would come together, maybe 3 or more, and they would hire a CFO at a network level rather than at a health center level. And that is for functions that are very costly, that are very complicated, and the learning curve is high, and they cannot afford to make failures, and where the expertise for that function may be very precise and very hard to find those types of providers in medically underserved areas. And HIT was a key area that we actually started investing in 2003. We did 6 pilot networks to do electronic health records back in 2003. The network since then, at that time in 2000, at the end of 2005, the adoption of EHRs in the health center program was a little less than 8%. The network since then, up to date, they have increased that adoption of electronic health records in health centers to just under 20%. So that's a pretty big adoption curve. And we did it through the network model rather than have individual health centers do it on their own. Why networks? Again, because it's costly, the learning curve is high, and the expertise is very specific. Now, I'd like to go through a couple. We have 2 grant programs that we do through the networks. We focus on electronic health records, yes, but the other one that we focus on, the other grant program, is called HIT Innovations. And this is using other forms of HIT other than EHRs. Many of the networks already have EHRs in place, but it is starting to get into areas such as health information exchange, using telehealth, personal health records, and starting to link behavioral health and mental and primary care together. So I'm going to go through about 6 examples for you. I have more slides that are here for your reference, but I'd like to give you a couple examples of what's going on the ground as we speak. 2 grantees are using their electronic information from their EHRs, one in Delaware and one in California. The one in Delaware is using that information to transfer to the State Immunization Registry and the State Department of Health. And patients within Delaware can have their entire record transferred to any Delaware Health Net provider instantly. And that's pretty remarkable. In California, the grantee there is working to use their information from their EHR to look at and coordinate care for patients with diabetes. They different types of providers and human services to coordinate that care. HRSA had a great collaboration, and still does, with CDC. HRSA, CDC, the state diabetes control programs, and the health centers, all different levels, came together to look at how they could care for our diabetic populations and our health centers better. And they had specific aims that they were looking at between a federal, state, and local partnership. And it was to increase the eye exams, increase foot exams, increase the number of times people come in to get their hemoglobin A1Cs done, so that's twice a year, 3 months apart, and eventually to decrease those hemoglobin A1Cs. That partnership is very effective, and going forward in terms of stewards of change, very good model to look at. We have about 12 projects that we fund to do health information exchange at a community level. The health centers are exchanging information from their electronic health records with regional health information organizations, with local hospitals, with behavioral health clinics, and state immunization registries. We have 2 networks that have used the information from their electronic medical record to establish a level 3 patient-centered medical home from NCQA. Going forward, when we look at meaningful use, there's a call for a lot of examples of what that means. These 2 centers and 2 networks are a good source of information to come to. They've been doing EHRs for a long time, and they've been using the data from their EHRs to care for patients for quite a while. We had 3 grantees that we have funded who are linking primary care and behavioral health. This is quite a challenge, and they've learned a lot through this. They're working to see what behavioral health specialists would see in the EHR, and also what information the primary care providers need from the behavioral health specialist to go into the electronic health record. We also have a center up in Boston, a network up in Boston, who's doing an e-referral that could also be replicated in terms of human services with their health information exchange. Their lag time between when the health center referral request came in and when the appointment was made went from 56 days to 2.5 days. The lag time between when that patient was seen by the specialist and when the specialist report came back to the health center, the lag time went from 32 days down to almost 10 days. In terms of migrant populations, we care for a lot of migrant populations. We have a health center up in New York, Finger Lakes Community and Migrant Health Center, who cares for migrant populations. We know that the cultural and language barriers with migrant populations makes it very difficult for them to access both medical care and enabling services outside of the migrant health clinics. The lack of providers in rural areas is significant. The distance traveled, training the providers who are caring for these populations is a challenge. They've used telehealth, actually, as a part of a solution to this in terms of specialty care, ENT, dermatology, oral health. They've used it for distance learning. They've used it for enabling services, such as interpreters and outreach. They've had some lessons learned, which I think we've all learned today so far. Learning from failures is critical. So they have great lessons learned that are a good reference going forward. They recommend starting small with a finite project, reaching out to those who have already done it, developing a community partnership with like-minded organizations, and beware of hype. We are trying to educate our health centers now around electronic health records. Slow down, do your due diligence, educate yourself, and ask a lot of questions. And technology, as Dr. Hunt said, is the easy part. It's really looking at a business model going forward. And their key is collaborate, collaborate, collaborate. That was their probably key lesson that they learned. Two more programs that I'd just like to highlight that I won't go into detail, but you have the slides, is our Maternal and Child Health Bureau is using electronic health information to improve the newborn screening system. The grant program has three functions: strengthening the newborn screening program in terms of the follow-up activities using real-time HIE, establishing minimum HIT language and terminology standards for use by the newborn screening programs. I think that's going to be key for all of us going forward, and to coordinate state and regional surveillance screening. There's a couple in Indiana and Colorado that are worth looking at in that program. Another example that we have of health information exchange involves our HIV/AIDS Bureau, using information electronically among different providers of care for persons with HIV and AIDS. And in New Jersey, what they've been able to do, it's kind of neat, they've been able to take that information and chart it and look at real-time data, allowing providers to quickly pinpoint clients and service utilization and identify areas of improvements in care coordination and delivery. So those are just a couple examples of what we've done in the community. And I think as you look at stewards of change, these grantees are definitely stewards of change. And it's good to learn from pilots and learn from their examples, and they will tell you what not to do in the future. I'm going to leave you with a couple resources going forward. When Cheryl came to OHIT, the first thing we did was to develop a toolbox in terms of safety net providers from their perspective. Very simple toolbox in a question and answer format. It goes anywhere from what is HIT, very 101 basics, to how to collaborate, to financing HIT. And the newest one that we have is children and HIT, which I think Cheryl will talk about during her presentation. And if not, I would advise you to connect with her. That is the website for the toolbox. The other thing that we've done in terms of technical assistance is this website in terms of Find a Health Center Control Network. All the programs that I talked about, you can go on this website. And in any of your states, if there's a network, I would strongly advise getting in touch with them and finding out what they're doing and how to connect with them. We've also done a number of HIT workshops, anywhere from HIT implementation to HIE to electronic prescribing and telehealth. We just did one recently on telehealth that was very well received. This workshop, I think it was beneficial to you all to take note of, is the State Leadership Workshop on improving EPSDT programs. The goal is really to connect our state MCH programs with Medicaid agencies regarding these programs with the aim of increasing the eligible children receiving screening and diagnosis. And if you go to this website, they will help facilitate meetings at a state level to do that. We also have done quite a number of webinars that are accessible on the website. Again, anywhere from financing HIT to collaboration to using telehealth to contract negotiations. This is also a very good tool to use it's for health centers, but it's also good for small primary care providers. Because the health centers provide not only health services, but enabling services and human services, the emphasis really is on that H for EHR. We require that our electronic health records for our health centers have a lot of functionalities that promote the use of enabling services and the connection with those. So we have guidelines that were developed by our health centers that are available for people to use. I'm not going to go through all of the ARA money that we received, and you can have those for your slides, but we do have a current opportunity out now for our health center controlled networks, and what we'd like to focus on is more vertical integration. And that's integrating more with specialty care providers, local hospitals, enabling services. So that opportunity is out now, and that closes at the beginning of February, February 5th. And I will end there. The last slide that I'd like to have people just focus on a little bit is broadband. One lesson that we learned is we funded health centers to do electronic health records, and about a year and a half later they come to us and say, we really can't do this because we don't have access to broadband. We either can't afford it or it's not near us. One of our locations in New Mexico is struggling in that area. There's a lot of resources for broadband right now that people are not aware of. So I always end with this slide because it's kind of a good foundation before starting too far down the road with HIT. I'd like to just end by saying HRSA is very, very open to new partnerships and also learning from you all. If you have suggestions on how we can break down silos, create synergies, do anything differently, we are very open to hear about that. Thank you.
This isn't a question so much as a comment. I feel very privileged to have worked with Mary Wakefield on a number of initiatives, and one of them is the Rural Assistance Center through the University of North Dakota. They have a website that's called RAConline, just one word, .org, that has, I think, the best GIS capabilities that I have seen. Chris Fulcher, the person who is in charge of it, actually takes a lot of public domain information and breaks it down into any number of slices and dices, any number of geographic configurations that you can imagine. So for researchers and planners and grant writers, I would highly recommend that tool.
Hello, everybody. I'm Denise Bazemore, and as Vernon said this morning, that Rick Friedman was not able to be here, so Bob and I are trying to fill his shoes, and believe me, they are not easy to fill, but we will do our best today. We work in a division that oversees the systems policy and systems funding for the Medicaid agencies. So we work with 50 states and the District of Columbia. We have 51 different entities that we oversee when it comes to the systems that support the Medicaid claims processing systems. Those are the systems that pay the claims. Medicaid is a payer to providers. It's a very enormous and very complex series of systems. And it is our job to oversee that. At the same time, we oversee the systems policies regarding eligibility determination for Medicaid. So we work both in the social service sector as well as in the health, between Medicaid and social services. And if you've worked in a state agency, you do know that in states there are 50 different varieties of systems that have been implemented. Not only do you have complex systems, but you have complex organizations. You may have the Medicaid agency in the same agency as social services that oversees the entitlement programs. In other states, they're separated. So think about interoperability and think about the complexities when it comes to just the administration of the programs and under what organizations they reside. Because when you have a commissioner that oversees all the programs, it might be easier to enable changes than it is when you're dealing with various departments of entitlement programs such as disabilities, substance abuse, mental health, and then you have food stamps, you have Medicaid, child support, child welfare, just to name a few. It's a very complex array of programs and organizations that we work with. We stay very busy, might I say. So one of the tenets, I think, of the Stewards of Change is that we're all here, and we're all here to learn. And most importantly, we are here to learn about each other's programs. I think that is one of the critical aspects of understanding where we can enact changes that really impact the commonalities between our programs. So it's really important for us to know, I'd say in detail, each other's programs so we know where the barriers are, we know where the rules and regulations and the laws all differ, And then we need to understand where the commonalities are, that we can sort of pick the low-hanging fruit, and that's a statement that Rick Friedman would say, pick the low-hanging fruit and have successes come from those areas where we have common areas that we can work together with and make changes and have successes. So in this vein, I do want to introduce you to the Medicaid program. I know many of you know about the Medicaid program, but from a national perspective, I want to highlight the footprint that Medicaid makes in this nation and how huge it is. And what we're doing is very, it's a lot that we have to look at. So here is some figures that I just wanted to throw up there. I want you to see that, you know, in the United States, we have 302 million people. I went online. I think it was before New Year's, so I didn't get the latest birth. But there are 302 million people in the United States. And when it comes to health care, we are spending $2.24 trillion. It's enormous. In Medicaid, we have 61 million beneficiaries receiving assistance. That's 1 out of every 6 human beings here in the United States. We're spending $358 billion, 1 out of every 5 healthcare dollars. And only, I think it was this year that I finally see that in the area of expenditures, Medicare has now exceeded Medicaid. And of course, you know why. The baby boomers are now turning 65 years of age. They're getting Medicare. And we're going to see that increase constantly. But here we still have, if you see the number of beneficiaries, we have on Medicare 45 million. So when you look at Medicaid and Medicare, Medicaid is the top of the list. When you look at the combined totals for people who are receiving Medicare and Medicaid, it's 106 million people. And we have a population of dual eligibles, people who are eligible for Medicare and their Medicaid, they're also Medicaid eligible. So our total expenditures are $789 billion. And just a few other little specifics here, that there is 40% of health care is paid for long-term care in Medicaid. It is the largest source of public funding for mental health care. And while nationally Medicaid covers 40% of all births, in 9 states, Medicaid covers 1 out of 2 births. It was actually 2.1. So when you are thinking about making changes to the Medicaid program, it really has to be transparent to the beneficiary, because it's like moving the Queen Mary, you know, full of people. You can't just make changes. You've got to be thoughtful about those changes and make them really be meaningful. And this just puts Medicaid, what is the scale of Medicaid in today's program? I mean, this just gives you an idea. The Medicaid beneficiaries, 61 million, if you compared it to other countries, you're talking about the United Kingdom, Italy, Burma, South America. It's equal to and larger than the gross domestic product of Greece, Denmark, Argentina, Venezuela. And this chart, and I can't see it on the screen here, but we broke down what the percentages are of where the nation's health dollar is going. And you can see where 16% is devoted to Medicaid and the Children's Health Insurance Program. We have private insurance at 35%, some out-of-pocket at 13%, other private, Medicare, but out-of-pocket 13%. These are people paying out of pocket, not with any health insurance. And those are just some statistics I wanted to show you. So this is just to give you an overview of the Medicaid program. And here you'll see growth in Medicaid beneficiaries, where we've gone from 1965 up to 2009. And you're going to see that increase more and more. And we talked a little bit about health reform. Health reform would bring in approximately 30 million more people. onto receiving health insurance. Many of those people will be coming through local departments of social services, receiving benefits through Medicaid because of the changes in the thresholds. So you can see the strain on the states and the local departments of social services in this time. State agencies are furloughing state employees. The resources are reduced. And you think of the influx of people that would be coming in through those local departments of social services, and this need for being able to exchange data across agencies, within states, is so critical for us to really be working on together. And these are just some more statistics. This shows you that the percent of total personal health care in the United States, 16% is devoted to that. In hospital care, we have 17%, but you look at nursing home, it's up at 43%. That is a small percentage of beneficiaries really cost a great amount of the healthcare spending in the United States. And I'm not going to go through the next slide, but this just shows you some rules for selected populations, the percent with Medicaid coverage. Of all the poor, 40% of the poor are covered through Medicaid. The near poor, it's 23%. Children, 27%. Low-income children, 51%. Go all the way to the end, you're looking at nursing home residents at 65%. Medicare does not cover nursing home care. I'm sure most of you know that, but many people don't. It is Medicaid that really covers nursing home care. I want to talk a little bit about the Recovery Act and the amount of funding that came through the Recovery Act. Of $787 billion that was approved through the Recovery Act, there was $86.6 billion that was approved. This is the federal, financial let me get this right, it is the federal matching percentage. And this is what states receive for their administrative funds. It's a share that the federal government pays, and that went up by about 6.4%. And that took a major amount of the recovery funds, because $149 billion was included in the healthcare spending. So those percentages add up to the $149 billion for healthcare. And you'll see that in the health information technology, 13% is devoted to HIT. That's $19.2 billion. COBRA is the Catastrophic Omnibus Reconciliation Act. That has to do with someone loses their job. They're able to have health insurance, but they have to pay the premium, the total premium. So the Recovery Act allowed for the premiums to be supplemented, so that $24.7 million went into COBRA. Part of the HIT funding also went to the states, not directly, but through funding. It is the state Medicaid agencies that are responsible for the incentive payments, making incentive payments to providers. So the Recovery Act actually changed the Social Security Act by allowing a 90% funding for states to use to build the infrastructure, to build the systems to support the incentive payment to providers. So even this afternoon when Dr. Ray was talking about incentives, we're still seeing incentives today, not so much about whale oil, but we're talking about adopting, implementing, and upgrading systems to meaningfully use EHR technology. But I think if you live back in the 1800s, whale oil is as critical in their way of life as having EHR technology is in our lives today. This slide is just showing you the upper right-hand corner. I just wanted to point out when it comes to IT spending, we spend less than 1% of IT spending to build our systems and to support our programs. It is unbelievable the amount of scrutiny that we do go through for spending that amount, but it just shows you in comparison what the non-IT is, what the information technology is, and what part of that supports medical assistance. So it is critical that we learn today, learn this week from others about our programs and how we can really make them interoperable so that we can exchange data and really move our states and our Medicaid systems into the 21st century. And with that, I'm going to turn this over to Bob, because Bob is going to talk about an initiative that we started some time ago. I'd like to say we started it a couple of years ago, but we really started it about, I think it's now 8 years. Yeah, it's been a while, and it takes a long time to make cultural changes, but it is possible. So with that, I'm going to turn it over to Bob.
Thank you, Denise. My name is Bob Guenthur, and I work on Rick Friedman's staff in the central office of the Centers for Medicare and Medicaid Services in Baltimore. I'm one of Denise's coworkers there. I think that Denise did a pretty good job of demonstrating the influence or the importance of Medicaid or the footprint that it has in the healthcare industry in general. Dr. Hunt spoke of the importance of achieving a critical mass if you're going to move anything forward, and I think that not only do we have a critical mass, but we have a little bit more than that. And I wanted to ask if there were any physics majors in here today. Okay, good, then I get to coin a new phrase. I was feeling a little deficient over there because the speakers this morning had all these cool catchphrases. It sounded really important, and I didn't have one. So I came up with significant gravity is what I think we have with Medicaid. And if I could see that on the illustration over there, I'd just be tickled. I am here to talk about an initiative called MIDA, which stands for the Medicaid IT Architecture. I don't know how many folks here, maybe by the show of hands, are at least a little bit familiar with MIDA and what it's... Oh, great. Okay, well, I'm going to turn it back over to Denise. All right. Probably good to start with a little bit of background in terms of Medicaid information systems, because what we're trying to do here probably is nothing short of a miracle. We're taking a look at information systems within the states that are decades old, that were basically designed to process claims, and that's about it. Over the last 30 years, these information systems haven't really changed a great deal, and each one is different. So you're looking at an archaic system that's hardwired, a lot of spaghetti code, a lot of COBOL, very hard to change, and you multiply that by 51, and it's quite a significant effort just within our sector of healthcare, Medicaid, to get some standardization, which is really the foundation for interoperability. You have to be doing things the same way and based on standards before you can really think about moving beyond your borders and being interoperable with other organizations. So several years ago, I guess it's 8 years ago, my, how time flies when you're having fun, some visionaries at CMS and within the Medicaid industry in general got together and said there's a better way to do this, that while our systems haven't been static, they really haven't matured to the point where we could share information. As a matter of fact, as Medicaid systems matured, they became silos within silos. We started with just a claims processing engine, and then we started to add modules or subsystems on for things like managed care, program integrity, decision support, and these became silos within the bigger Medicaid silos. So we were actually, on the surface, it looked like we were moving forward, but in essence, in terms of interoperability, we were actually taking steps in the wrong direction. So when these great minds got together, it was determined that we really needed to change the paradigm around, to get away from technology driving the way that business was performed in the Medicaid and say, let's start with the business end of it. Okay, let's go to the business users. When Professor Ray was up here this morning, I think he mentioned it was kind of funny about the concept of having a staff of management professors that had never managed anything before. We didn't want to make the same mistake or a similar mistake in redesigning the Medicaid information systems, so we went down to the operational level. We went down to the business users. We brought in states. We had workshops. We had pretty intense work sessions with the people that were actually doing the work, and said, let's start by defining in common terminology, in a common way, what it is you do day to day, and then what is it that you think could be done better, and let's capture that as well. And so we ended up with a concept of operations and some really good ideas, and no way really to go forward and implement this or deploy it or roll it out. So we needed a framework, we needed a structure, we needed some kind of organization that would allow us to move this new idea forward. So we took a look at what some other industries had done. The banking industry probably stands out as the best and earliest, probably most successful implementation of a service-oriented architecture. You can take your ATM card and now go anywhere in the world. I was at a similar conference, I think it was last year or the year before, and one of the speakers mentioned being on Easter Island and actually going to an ATM and swiping his card and getting money out. But the banking industry had really a profit-based motivation for doing that, okay? Interoperability, more efficient ways to do business, more convenience for the customers. They had a motivation there. Transportation, law enforcement were other good examples of industries that were siloed and moved towards interoperability. Of course, they had the catalyst of national security and a lot of money to move forward and do that. Within Medicaid, within healthcare, I think in general, we didn't have that strong catalyst. We didn't have that one uniting principle that everybody could get behind and say, this is why we need to change the way we're doing business. Recently, I think we've gotten some momentum. And Mr. Stein talked this morning about the importance of momentum, and I think that we've reached that point now within the healthcare industry in that through legislation and through a renewed national interest in improving our health across the board, we now have that catalyst to move forward, and we're getting more stakeholders on board because of that. So, what is MITA? MITA is what we call a reference architecture. Okay, it's not something that we could deliver in a box to a state Medicaid agency and they could take it out of the box and plug it in the wall and it would automatically boot up and would be interoperable and do all the wonderful things that we wanted to do in terms of health information exchange and health information technology. It's rather a template for implementers to use. It provides that common thread. It says that here's the foundation from which you will start when you redesign your information system for Medicaid. In putting this together, we came to the understanding that, hey, a lot of the business processes, because MITA is about taking the concept of what you do for a business and breaking that down to the business process level. When we took a look at the business processes, we discovered that there are other agencies, certainly within the federal government and certainly within state governments, that do a lot of these same things. And actually, I will put one slide up here that I think has a good example of this. We take a look at the Medicaid program, and it's broken down in MITA into business areas. If you take a look at something as simple as member management, okay, just about all agencies that deal with either healthcare or social or human services have members or beneficiaries or clients, and you have to identify these people, you have to enroll them in your program. I mean, there's a lot of commonality in terms of the steps you have to take to get your business goals accomplished. Some of these are unique to Medicaid or to healthcare, care management, program integrity management, but a lot of these operations management, program management, they cross agency barriers. They really cross over from health over to human services in a very good way. Is Rick Howard in the room this morning? Rick Howard is right here. Rick you'll hear from later on this week, but he really is, I would say, the national expert on how the MITA business processes cross over into the human services realm. And if you want to engage in a really interesting and productive conversation around that area, Rick is really the guy to see. And so we're fortunate to have Rick here reinforcing the MITA team. Okay, so where are we going with all this? We talked about MITA being a reference architecture. Right now we are in the process of finishing to flesh out the information architecture, the information part of it, MITA really has three major parts to it. There's the business architecture, and that's really what I focused on here this morning. Supporting or underlying that business architecture, you have, of course, the technical architecture. How are we going to implement this from a purely IT perspective, not an information systems perspective, but an IT perspective. And then we have an information architecture, which is really the key or the cornerstone to interoperability. If you're going to exchange information or data in a meaningful way with other organizations and other entities, you have to be talking semantically in the same context. You have to be using the same sets of standards. And so we're building our information architecture built around national standards where they are available and they're practical and they're trusted and they make sense. And so we think that what we're doing with MITA really is creating a foundation. If we can get all 51 entities within Medicaid to adopt the same approach and to begin to build their information system in this way, it really is a foundation to which other organizations we think can anchor themselves in terms of moving towards interoperability on a national level. Denise and I will be here through Wednesday, and I realize this was a fast and furious overview of what MITA is. And so please feel free, if you're curious, if you're interested, if you'd like to know more about how we think we're going to pull this off, come and talk to either one of us. We're very approachable, and we're happy to talk with you. And Denise, do we have time for Denise to come back up again? Okay, then that's all that we have. Thank you.
Good morning. It is truly a humbling experience to be at Yale, the kind of center of intellectual thought in this country, and a great honor to serve on this panel with federal officials who are so distinguished. I want to thank Daniel and Vern for this opportunity. They convinced me that a non-Fed could sit equally with this group, and then they put me between you and lunch. And I have to admit that given my history, my friends, if I told them that the very first thing that I did professionally in the new decade was to sit on a federal panel with federal leaders talking about federal interoperability, they would just have a great laugh. So here I am. The experience reminds me a little bit of a quote from Winston Churchill. He once said that there are three things that you should never do. You should never try to scale a wall that's leaning towards you. You don't really need a degree from Yale to figure that out. This is very important. You should never try to kiss somebody who's leaning away from you. And you should never talk to an audience or be on a panel that knows more about the subject than you do. I really figure that my only relevance to this discussion is as a consumer of federal policy, sometimes a critic, sometimes a partner, and that's the perspective that I'm going to bring to the conversation. I do have some sense through our work at APHSA, a membership organization that represents health and human services providers, of how federal policy plays out at the state and local levels, and the need for really substantive change if true interoperability is to become a reality. My thoughts for the need for integration really stemmed from my very first professional experience as a parole officer. I had great difficulty trying to navigate the vast human services system for people who were coming out of prison who had needs. I vividly remember one case of a prisoner that was sitting in the county prison for 6 months awaiting a psychiatric evaluation, court-ordered, from our mental health program. And I was told that there was no priority scale and they would just have to wait their turn. When you think about that, the huge expense, that all of us were drawing our paychecks with the same board of county commissioners that were on them. And I knew at that point that there really had to be a different way, and to some extent that's really defined my career. Since that time, nearly 40 years ago, I've seen great progress in human services. We've seen tremendous growth. Human services, health and human services now comprise, on average, 1/3 to 1/2 of most state and local budgets. We've witnessed the advent of technology and modern business practices and the creation of large umbrella organizations that were designed specifically to manage and coordinate programs better. But in spite of those advances, I would contend that services integration has yet to fulfill its potential in this country for a variety of reasons. No, we have not achieved interoperability nirvana. even with co-location, one-stop shopping, the adoption of common procedures and forms, new technology, team case planning, lead case management, and the host of other positive approaches that nation's human services leaders have taken. And while communications have improved, we fail to address the systematic and inherent structural challenges related to the categorical framework that we work from, both politically as well as operationally. It's a malady that we at APHSA call hardening of the categories. The federal role in addressing this dynamic, really, as in many states, particularly with locally based systems, has generally been passive. Most of the innovation for interoperability has occurred at the local level in an experimental way, in some cases very risky. Most recently, though, I've seen some really encouraging and positive developments and much attention to interoperability, really through much of the efforts of the stewards of change. And I'm very encouraged by these panel presentations. You know, it was great to have on our radar screen this need and some of the projects that are going on, the health information technology, medical homes, the health center networks, MIDA. And while these pockets of innovation are exciting, you know, a collection of projects doesn't a system make. So I want to take a little bit of time and talk about some of the positives, and I'm going to start with leadership. I believe that there is a new tone in Washington, D.C., and we at APHSA are very delighted with the presidential appointments who are drawn primarily from the ranks of our membership. Folks who were in the trenches, committed to forging new and aggressive approaches to interoperability, have experienced the challenge of trying to develop coordinated systems. They are willing to open doors and to challenge the status quo and to find space and regulation, the wiggle room and flexibility to help empower local and state governments to do better things. However, I really also believe that the balance of power it's a misnomer to think that it comes between the judicial, executive, and legislative branches. I really think it's between the newly elected and appointed officials with their fresh and fancy ideas and an entrenched bureaucracy of career civil servants that kind of grinds it down and slows it to a halt. That tension is the real checks and balances that exist in this country. And I just hope that we'll be able to make some progress in this arena, and I really am very, very confident because everybody, all of the federal agencies now are kind of singing off the same song sheet, and that is new and that's a plus. Health information technology has great potential to serve as a vehicle to create a new platform for interoperability if we do it right and if we think more holistically than we have in the past. It has broad public support, it has new resources, and I'm really delighted with Rick Friedman's article that was in the Stewards of Change packet, his contention that health and human services are interconnected. And I think we really see evidence of that when we start looking at progressive prevention and wellness strategies. They really have to be linked. My friends in the technology industry tell me that the real difficulty, the real challenge isn't the technology. It really lies in our politics and our policies and our business practices. Those are the things that are holding us back in terms of developing greater interoperability. I also want to encourage you to stay tuned to Rick Howard's presentation. It's very thought-provoking and exciting. It's kind of, I like to think of it as the big, bold, hairy, audacious idea of business processes. And finally, I'm really encouraged that we've already learned a lot about how to work together. We don't always do it well, but we've learned how to do it. And I think mainly through welfare reform. And I want to digress just a minute because I think that the lessons from welfare reform can inform this discussion. In my lifetime, welfare reform was the biggest change in public social service policy that I've witnessed. In exchange for the end of entitlements, states were empowered to design new programs to meet broad targets. And the results from that first decade, in the eyes of everybody, with the exception possibly of the 109th Congress and a few appointed ideologues, were outstanding. We saw a 60% decline in caseloads. We doubled child support collections in this country. We implemented a national EBT program. We created hundreds of thousands of new child care slots, and we put over 1.5 million people who had never previously been attached to the workforce to work. Those are just a few of the advances. But in addition to that, there were other lessons that were learned that I think can inform our interoperability strategies. We learned that welfare was simply a bad investment strategy, just like this string of categorical systems with redundant processes is a bad investment strategy. And welfare needed a complete overhaul, not just tinkering, to make something happen. We learned that the best approach really was locally driven, from the bottoms up. We learned that there was a clear need for interagency cooperation. It only worked because workforce, child welfare, child care, public welfare were kind of united around these new principles of self-sufficiency. We learned that partnerships were absolutely critical. It wasn't up to government to fix welfare. It took a combination of government, business, the private nonprofit sector, faith-based organizations, and others to make it happen. We learned that good data was essential. We learned that personal responsibility was vital and that people could rise to the occasion if given the right opportunities, access, and the incentives. It's kind of a microcosm of interoperability for welfare to work programs that we saw. But we also learned one other intangible thing, and I don't have any data to support this, it's just my own observations, that we could positively alter the nature of the federal and state relationship. That with the elimination of the federal AFDC quality control system, the federal role changed. It moved from one of overseer to provider of technical assistance. It was less authoritarian and kind of more empowering. That it was less hierarchical and more partnership-oriented. And both the states and the feds, I think, could feel a greater sense of accomplishments as we began to see some of the results coming in. I mean, we didn't hold hands and sing Kumbaya. We certainly had our differences. But I think we did find a better balance between the need for flexibility at the state level and accountability at the federal level with the new rules. So, you know, given those dynamics and a more favorable climate that I'm seeing today for interoperability with better politics, supportive technology, stronger leadership at multiple levels, greater acknowledgement of need, what are some of the areas of focus for the federal government? Well, first is to recognize that interoperability needs to be both vertical as well as horizontal for the best results. It just implies stronger collaboration, communication, and partnership. We must acknowledge the linkages not only between health and human services, but among human services programs and between public health, medicine, education, and other partners. We really should start with the low-hanging fruit. My favorite is APD reform, the antiquated process for getting procurement for computer technology. I think we need to start focusing in on a common taxonomy. We call things that are the same functions different in different systems, and I think that we can correct that. I was involved years ago in developing a dictionary, and when we started to do the research, we saw that most of those definitions were really not based in regulation, they were based in tradition. And so I think that that's a serious foundation step. We should start looking at uniform and comprehensive planning processes. Most planning that happens today is really compliance. It's not program planning. We have a dearth of good comprehensive human services planning that results in better linkages to outcomes in this country. And so I'm very, very excited to learn about Montgomery County's roadmap that's going to be part of this presentation. And to establish a national business architecture, Rick Howard's presentation, that's going to talk about the potential for greater interoperability, lower costs and risks, and to be more person-centric. My experience has been that it's much easier to find consensus in theory about interoperability. It is clearly the right thing to do in that it aligns with the multiple needs of clients. It eliminates redundancy, and it has more efficient and cost-effective potential. But my experience also has been, and I have battle scars to prove this, that it is shown to be much easier said than done. Our theory must comport to our operational reality. And as I tried to think of what I could add to a federal interoperability discussion, I realized that the dynamics of change, the practical questions and facets of interoperability aren't determined by where you sit at the federal, state, local level, or within health or within human services, but by what you're trying to accomplish. It's the what's of the elements of necessary requirements that are more important than the who's. So I want to share some practical questions that originally advanced in my article that was in the Stewards of Change booklet that was intended for states, but I think that may have some applicability to federal officials as well as they start going down this path. It's an article that Rick Howard calls to as my curmudgeon article, otherwise known as Musings from a Frustrated Integrator. So, from the School of Hard Knocks delivered at Yale, here is some lists that I think are relevant. Number one, vision and values. Can we agree on and articulate a clear vision and mission related to integration? Can it permeate our policy and our practice at all levels? Number two, direction setting. Can we agree on a common definition of needs and what success looks like? We did this with welfare reform to a certain extent. Performance measures. Can we agree on relevant data sets that measure outcomes? You know, we collect a lot of irrelevant data. You know, as Chris Fulcher from Rupri bemoans, he has this great saying. He says, water, water everywhere, but not a drop to drink. Data, data everywhere, but not a bite to think. You know, can we invent and can we develop good data sets that really do have meanings for planners? Stamina and stability. Is there a long-term strategy for interoperability that can outlive political change and the opposition that we face from categorical advocacy groups? Can and will the feds support and fund the development of an integrated information system that may not fit neatly into a categorical cost allocation methodology? That is why I am bald, folks. I have lost my hair over this fight. Can and will the feds permit the development of an account code structure that accommodates interoperability, reflects an investment strategy, and produces an unduplicated client count and cost associated per client and per family? Can and will the feds invest in cross-program training, breaking the paradigm that really favors specialization in this country? This number I think is very important. Will evaluators and auditors approach their reviews from a conceptual framework of integration or judge composite pieces of the system through individual program lenses? I have seen time and time again good integrated systems be torn apart by auditors who go in and just measure one little piece of it without having that perspective, that overview. On the personnel management side, this isn't just related to the federal government, but I think it's very important. Can the personnel system devise a strategy that rewards excellence in interoperable execution of activities? We reward specialization in this country. We hire and promote through that mechanism. We have lost the old settlement house, boarding house kind of casework excellence in this country that I think we need to get back to. So, I have one other important message in closing, and I'm really kind of short-circuiting this, Vern, to get us out there to lunch. But it's one important message, and I think that regardless of where we sit, and yes, the efficiency that can be related to interoperability is absolutely critical, but we can't forget the main purpose to maintain the interest of the people who critically need our services, the people in this country who have been left out and who have been left behind and for whatever reason don't really enjoy the bounty of the richness of this great land. We must stick to the mission of advancing interoperability at all levels so that that illiterate, mentally ill, homeless, jobless felon who is just getting paroled that I first met 40 years ago has a decent chance of getting the help that he needs. And I want to end with a quote from Edna St. Vincent Millay. It was from Upon This Age That Never Speaks Its Mind. Upon this gifted age, in its dark hour, rains from the sky a meteoric shower of facts. They lie unquestioned, uncombined. Wisdom enough to leach us of our ill is daily spun, but there exists no loom to weave it into fabric. Now, my own poem, perhaps that loom rests somewhere within this room. Thank you.